Does this look familiar to you?
Yes, that's mine.
Okay, sounds good. So doctor, can we please go to case number 4 here. So I see that you have a patient with an unknown scar. Is that correct?
Yes.
And you are okay with an induction of labor with an unknown scar?
After talking to the patient and asking the circumstance of her previous pregnancy and the reason for C-section, I had a high suspicion that it was likely low transverse, and so I felt comfortable with her induction of labor.
So you base your decisions on likely?
Yes.
What if it was a classical?
If I suspected a classical C-section, then I would tell her that and tell her that there's a high risk of uterine rupture during a trial labor, and I would not recommend a TOLAC.
So explain to me again how you managed to admit a patient for observation and then you discovered that she has incorrect dates.
So I did not take care of her during her prenatal care. And so she was admitted when I was on call for our group. And when I was reviewing her chart, I saw that she was not dated correctly and that she was less than 39 weeks. And so I discharged her. I reviewed with her the findings and that she should be redated and that she was less than 39 weeks and then recommended discharge home and then to discuss delivery with her.
What did you use for your dating criteria here?
Oh, so I looked at her last menstrual period and I was able to find her very first ultrasound and there was a discrepancy, and so I redated her.
So you used the first ultrasound?
Yes.
Okay, let's go to case number 7, please. So this is a patient that you said genetic counseling and aneuploidy testing. Please walk me through how you counsel somebody on their genetic testing options.
I would tell all my patients that they do have the option of genetic testing or aneuploidy screening and diagnosis. I counsel that because of her advanced maternal age, that she is at higher risk of aneuploidy. I would tell her that the most sensitive screening test for aneuploidy screening would be a cell-free DNA.
So let's assume you went ahead and you did cell-free DNA.
Mm-hmm.
Is there any other testing that you would do for this patient?
I would also recommend a maternal serum AFP starting at 15 weeks to assess for neurotubal defects.
I see. And you don't think you would see that on an ultrasound?
If it's a level 2, it definitely can be seen, but I've just seen in with my patients who had level 2 ultrasound that they couldn't fully see the spine. And so just to be on the safe side, I would still recommend
So let's assume that she had seen MFM at 19 weeks and they cleared her anatomic survey totally. Would you still offer them an AFP?
I would say that if they fully visualize the spine the spine, then I would say that it has a level 2 ultrasound has a pretty good sensitivity, and that it would not be necessary.
I see. So you don't think it adds value? If I recall correctly, isn't an abnormal AFP that is unexplained associated with an increased risk of IUFD? So don't you think that would be an important piece of information to know that would potentially change your management?
Given her age, her history of,
Okay, doctor, so how do you decide if you will allow somebody to TOLAC or not? I see in this particular case, this patient accepted TOLAC and then she stopped accepting the TOLAC in the middle of the admission. Is that correct? So I would like to know how you counsel a patient like this.
I would counsel that with a trial labor, that with a vaginal delivery, there is. So with this patient with a history of a cesarean delivery, I would counsel her delivery options, which include a scheduled repeat C-section or a trial labor.
Is there any circumstances that you would not allow somebody to trial labor with a lower uterine transverse scar and no other contraindication to a vaginal delivery?
If there was not,
Do
if we
you
did not have the
utilize, do you
facilities,
utilize any calculators
do I use any calculators?
to decide whether you're going to trial of labor or not?
I could use the,
I asked you if you used.
I would use a VBAC calculator to demonstrate the strength of or the probability of a successful.
So the number came back at 50%.
At 50%. Okay. I would counsel that to the patient. I would counsel like the risks and benefits of a TOLAC versus a repeat C-section. I would counsel that the risk of the risks of an emergent C-section are higher than compared to a scheduled repeat C-section. And based on decision making. Okay.
Okay, I am so sorry. I did warn you I was going to be difficult, right?
It's fine.
Okay, but I actually think you did pretty well under the circumstances, right? And my goal here is not to scare you guys, but to give you a full breadth of how the examiners can and cannot be. And believe it or not, a lot of times when I do these mock orals with you guys multiple times, I get ecstatic phone calls from candidates that say, oh my God, the exam was easier than what you had put us through. That is not correct. It's because we drilled you so many times that you were used to it. You didn't frazzle during the exam and you were very used to answering these weird, difficult questions, right? Does that kind of make sense?
Yes, definitely.
Because the more uncomfortable I make you and the more that you can get yourself out of a hole, the more likely that when you are put in an uncomfortable scenario in the exam, you will be able to be calm and answer as well. Correct? So I'll give you a little bit of feedback. I strongly advise you to still do an AFP irrespective of your anatomic survey, and you can easily say, yes, I routinely do AFPs because they give me information about open neural, they give me information about open neural tube defects, gastroschisis, omphalocele, and what do you call it, anencephaly, but they also offer me valuable information about the placental function. And if the AFP has unexplained elevation, that means the pregnancy is at risk of preeclampsia, fetal growth restriction, and those would be pregnancies that I would follow more carefully. Does that kind of make sense?
Yes.
So I would still do it, right?
Yes.
So because they do recommend when you do the NIPT is you should do the AFP with it. My recommendation is say when I counsel the patients about a trial of labor, I see their I use the VBAC calculator success rate. And if their success rate is above, the ACOG tells you 60 to 70%, then I say that their delivery is favorable. However, if it is less than 60%, I tell them that if they do trial of labor, there is an increased risk of morbidity with that trial of labor. And that is what ACOG says. And then even if they decline after that, then I tell them the risks of a TOLAC, primarily concentrating on the risk of uterine rupture and so forth, and all that sort of stuff. So that would be the approach that I would do here, right?
Yes.
Now, fair enough. You admitted somebody, you reviewed the history, you said that you found that this patient did not meet criteria of being 39 weeks. And I'm glad you did that, because you would have had to really justify why you did an elective induction at 37 weeks, right?
Right.
Mind you, on a previous scar, right? That would have been a very difficult scenario to get out of. Right?
Yeah. Yes.
That would have been, God help you if you were trying to convince somebody you did an elective C-section on a prior C-section at 37 weeks, right?
Yeah.
So that's the only way that which is not, you're not saying anything wrong, but that would be and then the short answer of it, you actually got it 100% spot on. ACOG tells you that if it is an unknown scar with a very low likelihood or probability that it's a classical, you treat it as if it's a lower uterine segment transverse. And you specifically said that. I had no, and I just tried to make you feel uncomfortable with the decision that you had made. Okay?
Okay.
But be proud. You stayed calm, you answered. I tried to frazzle you, you didn't really care, and you still answered, right? And even if deep inside you did not like what I was doing and you felt very uncomfortable with it, what you did very well is you did not show it to me. All right?
Okay.
So well done.
Thank you.
Okay. All right. So let's see. I don't see Dr. Brown. If Dr. Brown is here, can you please raise your hand? Oh, there it is, Dr. Brown. There you go. Right? Dr. Brown, can you hear me?
Yes, I can. Good evening.
All right, sounds good. I am sorry, you guys are alphabetically by first name, not by last name. So I have to kind of go down and find you guys.
No
All
worries.
right. Okay. Perfect. So let's go back. Is this your case list?
Yes, it is.
All right. Okay, doctor. Let's go to case number 6.
Mhm.
Can you please tell me what prompted you to deliver this patient at 35 weeks and 6 days?
Sure. This is a patient that came into the hospital with preterm labor, meaning she was contracting and had been dilating. She had a history that was known to have a prior classical cesarean delivery.
That she did not come in labor and she was not dilating. And you wanted to schedule this lady for delivery. At what gestational age with her history would you have scheduled?
Sure. Given her history of uterine rupture and classical cesarean delivery, I would deliver her between 36 and 37 weeks.
So you don't think this is worthy of delivery at 34 weeks?
Not in the setting of not having contractions or signs of preterm delivery.
Are there any specific precautions that you take in addition to the normal standard precautions with this patient since she has a history of uterine rupture?
Yes, I would counsel her to be very vigilant of any type of symptoms of contractions or abdominal pain, and to present right away to the emergency room or triage unit for evaluation, given that she is at a higher risk. We also do ultrasounds on these patients as well, and that you can sometimes look to see if there is thinning of the myometrium or any signs of like a uterine window on ultrasound examination. However, that's not completely accurate or able to predict a uterine rupture.
So do you think that the diameter or the thickness of the lower uterine segment is predictive of uterine rupture?
I do not believe there's a specific measurement. However, if you see a thinner lower uterine segment and the history of a uterine rupture, it would be an important counsel point to the patient that she has probably a higher risk of having another rupture, and to again be very vigilant of her symptoms and still go ahead and plan that cesarean section scheduled at 36 to 37 weeks.
Would you consider inpatient management?
I would not unless she had signs or symptoms of rupture or contractions preterm delivery or preterm labor rather.
I see. Okay, so let's go to case number 13.
Okay.
So it looks like this patient had a breech presentation in the context of fibroids. Is that correct?
That is correct.
And you offered her an ECV?
That is correct.
Okay. Do you think this is something that would decrease the likelihood of your success?
Yes, it is something I would counsel my patient on, that while I would still offer an ECV, that the fibroid sometimes can make it more difficult to be able to do a successful ECV.
I see. So under which circumstances would you absolutely not do an ECV?
I would not do an ECV for any patient that was already having a contraindication to a vaginal delivery.
Okay. Would you consider doing an ECV in labor?
Somebody that was actively in labor?
Yes.
I would opt for one if they were not having rupture of membranes, or if there wasn't like a fetal presentation, like a footling breech at that point.
And you think you'd be able to do an ECV when the patient is contracting?
It would less likely be successful in those circumstances. And if I were to offer one, I would be offering one in the operating room, so I would be able to
walk me through the steps of how you do an ECV.
Sure. Typically, what I'll do for an ECV is I will be first doing an ultrasound to confirm the fetal presentation, to see where the fetal head is, the fetal back is. I also like to do assessment of the fluid level and know where my placenta is at, as well as a baseline MST before I begin. I do offer them the option for spinal anesthesia for pain control, and I also administer terbutaline to have uterine relaxation. My first step would be elevating the fetal breech out of the pelvis, and then using my hands for gentle pressure, I would do either a forward flip or a backward roll maneuver until I'm able to successfully confirm that they are no longer in a breech presentation.
And then after you successfully ECV the baby, do you offer them an induction at that point in time?
It depends on what gestational age that I did the ECV. I traditionally will do one at 37 weeks, but however, if this patient is at term or 39 weeks or further, I would offer an induction of labor.
I see. And what do you tell them are the risks of a ECV are?
Sure. The biggest risk would be risk of failure. The other risk would be risk of rupture of membranes, fetal distress, placental abruption, and then if there was fetal distress, a need for emergency cesarean section.
Let's go to case number 15.
Sure.
So at what gestational age here did you diagnose the gestational hypertension?
She was diagnosed that day at 38 weeks and 2 days.
I see. And under normal circumstances, at what gestational age would you offer an induction of labor or delivery for somebody with gestational hypertension?
37 weeks.
How will that change if the patient has preeclampsia without severe features?
I still do an induction at 37 weeks when it's preeclampsia without severe features.
What about preeclampsia with severe features?
Then I would do that at 34 weeks.
Always?
I would always do it unless they were uncontrolled. I was unable to control their severe range blood pressures, or if they had signs of HELLP or laboratory evaluations of HELLP syndrome, or if they had persistent renal disorders, a creatinine greater than 1.1, or if there was any fetal distress.
Is that it? Would you offer them delivery earlier for anything else?
Those are the options I can think of at this time.
I see. So you don't think a platelets less than 100,000 is worthy of delivery?
That would also be a contraindication to continue expectant management with pre-E with severe features. And again, that could be also under the umbrella of HELLP syndrome.
I see. How do you differentiate between preeclampsia with severe features and HELLP syndrome?
So they can both have the elevated blood pressure of over 160/110. In HELP syndrome, you have signs of hemolysis. So you have a anemia. You also have elevated liver enzymes, twice the upper level of normal, and then you have platelet dysfunction, so platelets less than 100,000.
I see. Okay, so it seems like you had a 4th-degree tear in this patient. Is that correct?
Yes.
Can you please walk me through the steps of how you would perform a 4th-degree tear repair?
Sure. So once I identify a 4th-degree laceration, I would move the patient into the operating room for better visualization and have my equipment available. I would want to ensure that the patient has adequate pain control. At that point, I would administer a dose of ANSEF antibiotics. I would first repair the rectal mucosa with a continuous absorbable suture. I would then do interrupted sutures for the internal sphincter. Then followed by identification of the external sphincter. Usually I'll use some Alice clamps, and then I'll do an end-to-end approach with interrupted sutures. I would then complete the rest of my repair by closing the perineal muscles in a running fashion, and then the skin with a subcuticular suture as well. I would want to make sure.
Let's go to case number 14.
Sure.
So here you wrote that the patient has a category 2 fetal heart tracing, correct?
Correct.
So tell me what would make you move from a category 2 to a category 3?
Sure. So if the patient, if the fetal heart rate tracing had a persistent bradycardia, or if there was a sinusoidal pattern, or loss of variability.
Just loss of variability?
Absent variability.
So absent variability, with or without deceleration, makes you a category 3?
I believe so.
I see. So that means if you have a patient with loss of variability for an hour with no deceleration, you would consider this a category 3 and do a C-section if they were not a candidate for instrumental delivery?
Yes.
I see. Okay, so you had a patient here that also had, the same patient had postpartum hemorrhage. Is that correct?
That is correct.
So tell me, what is your initial management of postpartum hemorrhage?
For my initial management is to identify the cause of postpartum hemorrhage, as well as to notify for additional assistance, whether it being nursing and physicians, as well as anesthesia. In this patient's scenarios, it was uterine atony. So my first recommendation would be starting uterotonics, which I start with oxytocin. I also perform a bimanual massage as well, which helps me identify the cause, as well as to see if there's improvement with the oxytocin. At that point, if I am not noticing improvement, I would. Yep.
Okay. How did you feel you did?
I mean, it was a whirlwind, but I feel like overall okay. But then there was a couple things you made me question myself on that I was like, I need to look that up again to make sure.
So if you've noticed, I didn't wait for you to finish some of your answers. Do you see how that's very disturbing, right?
Yeah.
Okay, unfortunately, that's what the examiners will do sometimes, but that's actually not a bad thing, because it usually means that you have started the answer in a way that has convinced them that you're going to continue to answer correctly, right? But you also want to make life easier for yourself. So when I asked you, when do you deliver preeclampsia with severe features? Wouldn't a better answer have been, I usually deliver them at 34 weeks unless there is a contraindication to conservative management, right? So now they can choose what to do, right? But you jumped straight away to telling me what you would, which means if you wanted to do that, that's fine. But then you can say contraindication to conservative management such as. So that means you're not telling me an exhaustive list, and I can't attack you and say, what about platelets? What about pulmonary edema? What about, right? So I could have gone through that loophole. So if you want to say something like that, always use the word such as. That means I'm not giving you an exhaustive list. I know there is more, right?
That makes sense.
Does that kind of make sense?
Yeah, so it just gives a couple of examples.
Yes. So then, but you said such as, which means that you're telling them, I know there is more. And they'll say, okay, this sounds very, very reasonable and all that sort of stuff. Now, your category 3 definition was not correct. Okay, so category 3 always starts with, right, a sinusoidal pattern. That's a different entity, which you got right. But it always starts with absent variability plus. Okay, plus bradycardia, plus recurrent late decelerations, plus recurrent variable decelerations. Either of these three would make you a category 3. But unfortunately or fortunately, just loss of variability does not, now it may not change your management, but my question was specifically about what do you do or what constitutes a category 3, right, delivery. And I would look it up, but I don't think you can do an ECV in a laboring patient because you'd have to give them terbutaline, you'd have to do all that sort of stuff. But I think everything else that you did, you got spot on. I do love the fact that you're always calm and collected, and I do love the fact that when I quizzed you and pushed you into that category 3, what did you say? You didn't say absolutely I'm 100%. You just said this is what I believe is correct. So you're like, okay, I'm giving this a chance that it may not be 100% correct. Okay, but good job overall. Practice makes it perfect. And I used today the philosophy that I used in is I didn't let you finish a lot of the sentences, and that can be very unsettling. But if they do that in the exam, this should be very reassuring for you because that means that you're actually doing pretty well. All right?
Appreciate it.
Perfect. Did you benefit from this little discussion?
Yes, of course.
All right, sounds good. You take care, okay?
You too.
All right. If you see your name, all right, Dr. Ibuzo, I don't see you on the webinar, but if you're there or, can you please raise your hand? Okay. If not, I did see Dr. McDowell, right? But just so that I can find you much quicker, can you raise your hand? There you go. Okay. Dr. McDowell, can you try talking so I can make sure I can hear your voice?
Yes. Can you hear me okay?
I can. All right, you ready?
I believe so.
Where else would you volunteer to be put under the microscope except in the wonderful world of medicine, right?
So true.
But here, better than the exam, right?
Agreed.
And I can tell you, I've been doing this for a very, very long time. Thankfully, I've had a tremendous amount of success with the people that they go out of the exam and they say, man, that felt so close to what the exam was like. So you got to trust me on this. I really am not trying to be mean to any of you or hard on any of you. I promise you, I'm a nice guy. And that's why I'm not an examiner. That's why I'm helping you guys. I'm not on the other side. But I've got to mimic the exam, okay?
Perfect. Yes, thank you.
Okay. All right. Is this your case list?
It is.
Okay. So, doctor, can we go to case number 11?
Yes.
So I see that this is a patient with factor V Leiden heterozygous, correct?
Correct.
Now, tell me why you offered this patient anticoagulation.
So for this patient with factor V Leiden heterozygous status, she also was morbidly obese with a BMI of 43. So she had an additional risk factor in addition to being pregnant for having a VTE.
I see. So do you routinely offer factor V Leiden heterozygous anticoagulation? Or is that what the American
So-
College recommends you to do?
So for a patient with this kind of inherited thrombophilia without a history of a VTE, she does not qualify for anticoagulation outright. So no, I would not typically.
Okay, but I also see in case number 34, you have a very similar presentation, and you also offered her anticoagulation.
So for this patient, I offered postpartum anticoagulation for her. As in the postpartum period, there is an increased risk for VTE.
So even without a history of VTE or a strong family history of VTE, you would still offer them postpartum anticoagulation with just a factor V Leiden.
It can be considered. It's either surveillance or
What is your practice?
anticoagulation, to my understanding.
What is your practice?
I typically do offer anticoagulation for these patients because of the increased risk of VTE in the postpartum setting.
Okay, I see. So tell me what thrombophilia would you automatically offer anticoagulation for?
I would recommend that for any high-risk thrombophilia. So factor V Leiden homozygous, prothrombin mutation homozygous, antithrombin deficiency, protein C and S deficiencies.
Are those considered high-risk thrombophilias?
The protein C and S.
Yes. Hello?
Is that what you're asking, if those are high risk?
Yes.
Yes, I would for those.
I see. So what are your low-risk thrombophilias?
So low risk would be factor V Leiden heterozygous, prothrombin heterozygous. And those are for sure the ones that I remember at this time.
Okay. So talk to me about case number 37.
Yes, so this patient had a history of thrombocytopenia. She had a history of this in her prior pregnancies and carries this diagnosis outside of pregnancy as well. At baseline, her platelets are between near 100, but in pregnancy, they do typically drop to between 50 to 70,000.
Okay. Did you seek help of a hematologist or a maternal fetal medicine doctor in the management of this patient, or you managed her yourself?
So since she was a G3 P2, she had hematology help in this pregnancy before, or in her pregnancies before. So I truthfully did not seek assistance with this patient based on her prior pregnancy history.
What made you transfuse this patient just 1 unit of packed red blood cells as opposed to more than 1 unit? And was it for the thrombocytopenia, or was it just specifically for the postpartum hemorrhage?
It was for the postpartum hemorrhage. This patient actually had never been offered an epidural in her prior pregnancies based on her platelet counts. My anesthesiologist, after reviewing this patient's case and care, he did say that he would offer an epidural for the patient. So she did receive one. As you can see, it did say a delayed postpartum hemorrhage. So her bleeding actually initially right after delivery, her blood loss was 50. And so was not seemingly to be an acute obstetric hemorrhage. But we feel that if her bladder might not have been drained well enough following the delivery, and so then this resulted in a uterine atony in a delayed fashion. So actually my partner managed her hemorrhage after her delivery.
Okay. So what did you base your decision to transfuse the patient? Like, what was the factor that made you decide to transfuse? Was it vital sign instability? Was it hemoglobin? And if so, what is your cutoff for hemoglobin transfusion?
Yeah, so for this patient, it was hemoglobin and she was symptomatic. So she had a hemoglobin of 7 and felt lightheaded and dizzy with ambulation. So she was counseled about her options for management of this and opted for 1 unit of packed red blood cells.
Okay, let's go to case number 40.
Yes.
So why did you offer this patient a primary cesarean delivery?
So this patient has active Crohn's disease with perianal involvement. She was actively being managed by her gastrointestinal doctor, and their recommendation was for cesarean delivery.
So if they were not involved in
talking with
this care, if they were not involved in this care, what decision would you have made?
Since she had active perianal involvement, having a vaginal delivery would increase her risk of fistula. So I think I would want to get them involved. I would consult GI.
If they're not available, you're the only one making the decision. What would you do?
So I think that I would offer her a primary cesarean delivery to reduce the risk of worsening her active perianal disease.
I see. Okay, doctor, let's go to case number 47.
Yes.
And let's pretend that I am the patient. Tell me, what would
Okay.
you tell me about permanent sterilization?
So I would counsel you about the 100% permanent nature of this procedure, and that you needed to be very sure about proceeding with this, as there would be no way to conceive naturally after removing the fallopian tubes. I would also discuss that
So you
this
said
would be true.
there's no failure rate of a self-injectomy?
There is a failure rate with salpingectomy, depending on how this is performed. If the tube is not taken off at the corneal margin. However, to my knowledge, we don't have data particularly pertaining to the exact number.
I see. All right, time. How did you feel you did?
Oh, there were things that I was, why did I say the thing about the number? I don't know.
Yeah, it's
Okay.
You did well, right? You did well. I don't think you had any major glaring problems, except you did struggle to tell me the differences between high risk and low risk thrombophilias, right?
Yes.
So protein C, protein S, low risk thrombophilias, right?
Yes.
Factor V, Leiden, heterozygous, all, now homozygous becomes high risk, right? Antithrombin 3 becomes high
Yes.
risk. And then you forgot to tell me compound heterozygous. So if you have 2 heterozygosis, that also equates to a high risk thrombophilia. And of course, prothrombin is a low risk thrombophilia. Now, anticoagulation postpartum, that's totally justified. So you've no problems with that after you counseled the patient and all that sort of stuff. It tells you that you can, antepartum, you offer them surveillance, and then postpartum, you could do surveillance, but it's not unreasonable to offer them anticoagulation. Now, if they have a strong family history and a first-degree relative, then even with factor V heterozygous, you can offer them anticoagulation pre and post, right? Now here, the obese patient, right? It's not an ACOG's guidelines,
Yes.
right? But you said that you counseled the patient, you told her the pros and the cons and all that sort of stuff. So I think it's reasonable to say I looked at all of her risk factors together, and we after we talked about the pros and cons, we felt it was reasonable. Or if you want to make life easier for yourself, you can say this was also postpartum anticoagulation.
Okay.
Because
Yes.
it's also less ambiguous, right? Because I'm not aware of any guideline that says antepartum. There are some guidelines for postpartum and C-sections and so forth, but I'm not aware of any recommendations for just obesity to put them on anticoagulation, unless I'm wrong, but I can't recall anything off of my, off the bat right now. Okay, but you did
Yeah,
well.
that makes sense.
Okay, you did well. So I'm also the person that doesn't, I'm never telling you to lie, but I'm also telling you to use the path of least resistance and the path that equates to what the guidelines are 100% of. Nobody's going to fault you if you say, I gave this lady postpartum anticoagulation after I weighed all of her risks, right? Which is now the C-section, the factor V Leiden, all of that sort of stuff. All right.
Yes.
I do think that now that we've cut down the number to only 6 in the hot seat, we're able to give each one of you about 15 minutes with feedback. And I think that is more helpful. Wouldn't you agree?
Definitely agree. Thank you.
Okay, perfect. Thank you very much. Right. And I apologize again for being difficult
Thank you.
for some of the questions. All right.
I
Okay.
appreciate it. So thank you, and please keep doing it.
All right, sounds good. But you, like I said, you did well. Okay. All right. I see Dr. Meyer, but I do not see Dr. McCohen or McCohen. Is that right? Dr. McCohen, if you're there, please raise your hand for me. All right, so I think then we can go to Dr. Meyer, right? Dr. Meyer, help me with my eyesight that is no longer there, and if you can raise your hand as well, that would be helpful for me. There it is, I see it. Okay. Dr. Meyer, if you want to try, yes, I can definitely hear you now. I just need to find your case list. All right. And thank you for not running away after you saw what you saw.
Yeah, thanks.
Sounds good. All right. So imagine this, right? I know none of you guys are residents, but my poor third-year residents every day, they're like, man, it's like coming to Dallas every day when we're rotating with you, right? So at least you get me once in a while, not every day, right? All right, does this case list look familiar to you?
It does, yes.
Okay. So obviously, I'm not going to ask you the same factor V Leiden question, right?
Mm-hmm.
Sounds good. So we'll leave that there. Okay.
Okay.
So doctor, let's go to case number 7.
Sure.
So I see that this patient is GBS unknown, correct?
Correct.
So tell me how you would do a GBS swab.
Sure. So I do a GBS swab with a vaginal rectal swab. So I insert the swab into the introitus about 1 centimeter down the perineum, and then into the anus a small amount, and then I put that order in. Yeah, so that's how I do it.
Okay. Under which circumstances would you order sensitivities?
So I would want to know if they're allergic to penicillin, and then I would do clindamycin sensitivity.
I see. So irrespective of what the allergy is, you would do sensitivities?
I do always order the sensitivities so that I have that. I typically give not a cephalosporin if they have a high risk allergy such as anaphylaxis, high shortness of breath, things like that.
Okay, so tell me here, when do you give GBS prophylaxis in a GBS unknown patient?
Sure. So for all patients less than 37 weeks with GBS unknown, I give GBS prophylaxis. Additionally, if a patient was GBS positive in a prior pregnancy or had a previous infant with GBS bacteriuria, and if
I'm sorry, prior infant with GBS bacteriuria?
Sorry, no, with GBS disease, so GBS sepsis. And if a patient is greater than 37 weeks, I would give it if a patient had been ruptured for more than 18 hours, if she had a temperature of greater than 100.4.
I see. Now, are there any circumstances where you would skip doing the GBS swab in pregnancy?
If she had had a GBS UTI earlier in pregnancy, I would automatically be treating her for GBS during labor, but otherwise I always get a GBS swab.
So even if they had a history of baby with GBS sepsis, you would still do a GBS swab?
Now that you bring that up, I think I would be treating them anyway, so it wouldn't be necessary to get that swab in retrospect.
So with no penicillin allergy, right?
Yeah.
Tell me what would be your GBS intrapartum treatment?
So I typically use penicillin. I give 5 million units for a loading dose, and then 2.5 units, a million units every 4 hours.
Okay, so let's assume that she's GBS positive, penicillin allergic, you don't have sensitivities. What medicine are you going to give in that scenario?
So I would determine if it was a severe penicillin allergy. If it was a mild allergy, I would give cefazolin. If it was a severe allergy, I would give vancomycin.
Okay, I see. So let's go to case number 6.
Okay.
So this is a patient who has a history of a cesarean delivery ×1, correct? And she's
Yes, and 2 successful VBACs.
Okay, so if in counseling the patient asks you, what would be the thing that would make me most likely to have a VBAC, what would your answer be?
If she went into spontaneous labor.
So it wouldn't be the fact that she had a VBAC in the past?
That does increase her likelihood. Yes, I think for this specific patient, I apologize, my thought about your question was for her specifically when she was delivering, what would be her most increased risk, but her successful VBAC.
In general, when you counsel the patient, what would be the strongest factor for success?
A history of a successful VBAC, yes.
Okay, so tell me some of the factors that would make it less likely for her to have a successful VBAC.
So if she had not had a prior vaginal delivery, if she does not go into spontaneous labor, if her previous cesarean delivery was for an arrest indication, if she has obesity and increased maternal age, so advanced maternal age.
Okay, I see. Do you in your practice utilize a VBAC calculator to counsel your patients?
I do. I utilize the MFFU VBAC calculator to counsel my patients regarding VBAC and TOLAC.
Okay, so let's go to case number 8.
Okay.
So this is a patient who had a history of preterm delivery. Is that correct?
That's correct.
So let's say this patient now did not present to you at 34 weeks, but with the history of the preterm delivery, she comes to you at 12 weeks of pregnancy. Tell me, how would you counsel this patient and what would be your management plan?
I would talk to her that with a history of preterm delivery, she has at increased risk of a preterm delivery this pregnancy. And what we can offer is vaginal progesterone as well as serial cervical length starting at 16 weeks.
Would you not offer her a cerclage?
I would not, just for a history of preterm delivery.
So under what circumstances would you offer this patient a cerclage?
If she had a history of a cerclage in a prior pregnancy, if she had a history of cervical insufficiency, and then during this pregnancy.
What are some of the things?
I apologize, can you repeat the question?
I'm sorry?
Oh, no, I just wanted you to repeat the question. Go ahead.
What would make you suspect cervical insufficiency?
If she had a preterm delivery, particularly before 34 weeks.
So you would put a cerclage for that patient? Because you said cervical insufficiency, you would put a cerclage straight, right?
If she had a history of cervical insufficiency in the past, then I believe that would be a criteria, but I would need to look that up.
Okay, so what would be the presentation of somebody with a cervical insufficiency?
So it would be cervical dilation, painless cervical dilation, not in the setting of labor or any infection or ruptured membranes.
Okay, so that would be the type of person that you would offer them a prophylactic cerclage in the next pregnancy, correct?
Correct.
And in the setting of a prior preterm birth, when would you offer them a cerclage?
About 12 weeks. I do have my maternal fetal medicine colleagues do this, but that's what I would anticipate.
No, let me try to clarify the question. In a setting of just a prior preterm birth, no cervical insufficiency.
So I would monitor their serial cervical lengths, and if they had a cervical length less than 2.5 centimeters.
I see. Do you typically do cerclages, or do your MFMs in your institution do cerclages?
At my institution, we refer to maternal fetal medicine.
I see. But if you were left to manage this patient, what type of cerclage would you put?
My understanding is that the maternal fetal medicine would offer a McDonald cerclage. Typically would be the one that I've seen most commonly.
What type of suture do they use?
So they use an Ethicon suture, a permanent suture.
You want to put a permanent suture in somebody's cervix?
Yes, because it's going to be taken out prior to delivery.
How did you feel you did?
Okay, I got tripped up on that, and I know I've read it a million times.
Right, and there's a setting of being, if there is, but you recorrected and got it right. Okay, you initially was like, okay, what do I do? So remember, there's 3 indications for cerclage, right?
Yeah.
There's history indicated, and that is somebody who presents with painless loss, mid-second trimester, no cramping, no contractions, no evidence of labor, right? So then you would put just based on their history, you'd put a cerclage in a subsequent pregnancy, correct?
Correct.
It doesn't matter what their cervical length is, it doesn't matter. And then there's the exam indicated, which is very, very often forgotten, but this is somebody who presents with, let's say, pressure, vaginal discharges. You examine them, they're 1 to 2 centimeters, less than 24 weeks. Then you can offer them an exam indicated cerclage because you're worried that they're going to progress. And then last but not least would be the ultrasound indicated cerclage. And if you want to follow ACOG to the T, it would be in a setting of a prior preterm birth with a cervical length less than 2.5, and you could potentially counsel them with no prior preterm birth and a cervical length less than 1, correct? Now, the other part of it is,
I have a question, sorry.
Yeah, go ahead.
So when you were asking me, you were mainly kind of asking me about history indicated and then got to ultrasound. I did want to talk about like the physical exam too. Should I have just brought that in, or should I just be like, there's three indications?
No, I didn't ding you for that one. I didn't. I
Okay,
never asked
I know
you.
I got the history wrong. That's my bad. But yeah.
No. I never asked you about ultrasound. I'm just reviewing it for now. You would have not gotten points away for because I never went that route. I just said cervical insufficiency. What is cervical insufficiency? No. I'm just completing the answer just in case they go that route.
Okay.
No. So you did not. That would have not because I never gave you an opportunity to tell me the three indications. Not at all did I do that.
Got it.
Now, did you notice how I took a subject or a topic that is considered relatively easy, like GBS?
Mm-hmm.
And even though you got it right, but there were a few times where I felt you were like, okay, I'm second guessing myself. Did he just really ask me how to do a GBS swab? Yes. Right? And
Yeah.
historically, that question has been asked. How do you do a GBS swab? And you're like, well, I do it every day. What do you mean? Because there is a difficulty sometimes in my hand does it automatically, but then when I'm trying to give you the steps of doing that, it becomes difficult. Now, I quizzed you back and forth on GBS and GBS unknown and all that sort of stuff. And yes, if you have a history of a GBS sepsis, you don't have to do a GBS swab because you're going to cover them intrapartum anyhow, right?
Mm-hmm.
Perfect. All right. You did well. You really did well. I don't have a lot of complaints. Again, what I'm happy about is most of you are not getting frazzled. You're maintaining your calm and composure. You're not making up answers that are not associated to anything that is, not smart. Okay.
Thank you. It's very helpful. Thanks.
Perfect. Thank you very much, and I appreciate your courage to step up in front of your colleagues. All right. Take care. Okay. So I don't see Dr. Rivera. Does anybody see Dr. Rivera? Are you there? Okay. If Dr. Rivera is there, please raise your hand. All right. If not, then we will go to Dr. Rondinelli because I know that I saw that she was there. Right, if you want to help me and raise your hand, that would be wonderful. Oh, wait a second. I see Dr. Rivera. Did I? Yep, Dr. Rivera. I apologize. My eyesight is no longer as good as it used to be. All right. Dr. Rivera, there you go. Okay. I'm glad you raised your hand and I'm glad that I saw you. Right? Can you hear me?
Yes.
Okay, and you did submit a case list?
Yes.
All right, let's find it. Okay. Okay, did you submit it? Do you see your
No, I haven't seen my name. Maybe it's in the September. I
This-
did the hot seat for September only, so maybe that's why it could be.
Okay, so this is August. You don't see your name here, correct? All right.
No.
Let's do the September one. Let's do that. I don't see it. You don't have any other names that you're under?
No. Maybe go up to the C. No, not there. I can send the list if you'd like, if you want to take someone else, and then
Would you like me to give you a generic list?
I would prefer to use my list, but I could do this, and then on another webinar we could use mine. But that's all right.
Whatever you want. I can skip you and then just not put you on and we can just go back to your
Yeah.
list when it's submitted.
let's do that. I did send it to the MP3 email. I don't know if I should send it to your email directly.
Well, you can. I'll get it to whoever needs to get it as well. All right. Perfect. I apologize, Dr. Rivera, but I promise we will get back to you at some point. All right.
So not today, just to know, because I am on call.
Okay. If you want to send it to me, sure.
Okay.
Here. So let me do this. If you want to do that, just send it to me, and then we'll just come back to you at the end of the webinar. How does that sound?
Sounds perfect.
Okay. But send me your OB. Okay.
Of course.
All right. Although as an MFM, I still quiz you on other stuff, but I'm preferring to stick to the OB right now. All right, there you go. So just send it to me. So we'll just come back and circle back. All right.
Okay, perfect. Thank you.
Okay. So Dr. Rondinelli, if you want to raise your hand for me for a second. I know I saw your name. There it is. Okay. Perfect.
Hi, good evening.
Hi, how are you?
Good, thank you.
Good. Did you send your case list in the
Yeah,
September?
it's right there.
Okay.
It's right there.
Yes, I saw it, and then when I changed the format, it of course went away from, there you go. Okay.
Uh-oh.
That's okay, we'll download it, not a problem. Is that your case list?
Yes, it is.
Okay, sounds good. So now your case list will be downloaded on my computer.
Okay.
All right, sounds good. Okay, so doctor, let's go to case number 7.
Okay.
So I see that you have attempted a vaginal delivery of twins. Is that something that you're comfortable doing?
Yes, I am.
Okay. Under which circumstances would you not offer a trial of labor to a twin pregnancy?
So I would not offer in general, I would not offer a trial of vaginal delivery if there is a contraindication to a vaginal delivery. Similar as if it was a singleton, that there was a contraindication. So some examples would include a mono twin gestation. I would not do it if there were any severe congenital malformations in either of the fetuses. I would not do it if there was if there was a discordance in the fetuses of greater than 20%, particularly with baby B over baby A.
So, doctor, not in any of your discussions did I hear that the presentation mattered.
Sorry, I should have clarified that the baby A should be in the vertex position. However, I do offer vaginal delivery if baby B is vertex or in the breech position.
I see. Is there a gestational age cutoff where after or before you would not offer a trial of labor if the second baby is malpresenting?
Typically, it's over 32 weeks, or if the gestation is under 32 weeks, I would not typically offer vaginal delivery, or if the fetuses are less than 2,500 grams.
I see. Okay, so you said that you deliver you said irrespective of the presentation of the second twin, you would offer them a vaginal delivery. So first baby comes out. Please walk me through how you would evaluate and deliver the second baby.
So in any time I am considering vaginal delivery of a twin gestation and baby B is breech, I always counsel the patient first, and I typically perform the delivery in the operating room if feasible. I usually have an assistant with me to perform transabdominal ultrasound at the time of the delivery, especially after baby A is delivered, to determine which position that baby B is in. If baby B is still breech, then my goal is to have baby B delivered through the cervix as quickly as possible. So I perform rupture of amniotic fluid, and I grasp the fetal the fetal feet and then pull it through the cervix.
Okay, so let's say while you were doing the maneuver of your breech extraction, the head does not come out. How would you try and rectify that problem?
So the first thing I would do is notify the anesthesia team, which is always present during my my twin deliveries. I would notify all the staff in the operating room. I would administer a tocolytic, whatever's available in the operating room, the one that has quick accessibility, and I would try to with an assistant, perform maneuvers to help to flex the head and adjust the position of the fetus to help with the delivery of the impacted head.
If all of your maneuvers are not successful, what other thing can you potentially do?
So I'm familiar that there are type of forceps that you can use called the Piper forceps, which can facilitate delivery of the breech fetal head. However, I'm not trained in the Piper forceps, and so my next step would be to perform the Durson incision on the cervix.
But if you're fully dilated, what would you be able to cut? Because a Durson incision is to cut the cervix. So if you're fully dilated, what do you have to cut?
Yeah. I suppose if the cervix is fully dilated to 10 centimeters and 100% effaced, you wouldn't have substantial amount of cervix to cut at that time.
So you just watch this baby?
No. So then I would begin prepping for cesarean section.
How would you deliver this baby by C-section when half of the baby's head is out? Or half
Then
of the
I would attempt to perform something similar to a Zalvinelli, where try to
So doctor, do you put forceps in your practice?
I do not.
You do not. So under this setting that is urgent and you are running out of options, you would not want to put forceps yourself to try and deliver this baby because the baby's stuck.
I would not, because I believe that if I were to attempt to use the Piper forceps in this scenario, then I would probably cause more harm than success in this particular case.
I see. Let's go to case number 9.
Okay.
Okay. So what do you mean by inconclusive genetic testing?
So I offer all my patients genetic screening using the non-invasive prenatal testings with cell-free DNA. And when I'm counseling the patient, I do inform them that there are different possibilities in the results that we can obtain, and one of them is inconclusive genetic screening. When the testing comes back with this result, I typically counsel the patient that this can mean one of many things. It can mean either the testing was performed too early enough to obtain a substantial amount of fetal fraction in order to obtain a result.
Explain to me inconclusive. Is that insufficient sample, or was it that they thought there was a syndrome but they couldn't figure out what it was? What is your meaning of inconclusive?
In this case, it was because there was a low fetal fraction.
I see. So
Twice.
It's twice.
Yes,
So it seems like this patient declined to go to MFM. Is that correct?
that's correct.
So with this insufficient fetal sampling, and I know you may have been starting to answer this question for me, but what would you tell the patient are the possibilities?
So if it's the first result, I would offer the patient the opportunity to retest using the same test. But after a second inconclusive or low fetal fraction on the second attempt, at that time, I do not reattempt the draw, and I discuss the further options with the patient in addition to the implications that the result can mean.
Which are?
So either it was performed too early, sometimes it can be a low fetal fraction with an increased maternal weight or BMI. It can actually mean that there is an abnormal genetic result that is not being
Okay, so let's say
recognized.
go ahead and you proceed with a detailed anatomic survey.
Mhm.
And on the anatomic survey, you find some markers that are suggestive of syndromes.
Yes.
So first of all, I want you to tell me some of the markers that would make you believe that there's an increased risk of a syndrome, and then how would you counsel the patient when this occurs?
A fetal growth restriction, if there's an echogenic intracardiac foci in addition to echogenic bowel, if there's hydrocephalus, fetal edema. Are you still there?
Yeah, I'm just
Oh,
trying
sorry.
to
Okay.
open my.
Okay, I
I'm
thought it all
trying to
shut down.
open my email
Okay.
to get Dr. Garcia's case list, but yes.
Okay. Yeah, and if there are any cardiac malformations, if there's an absent bowel, if there's a cleft palate, clubbed feet.
Okay, time. How did you feel you did?
Okay, but sometimes I feel like I can think things in my head, but they're not coming out the way I'm thinking them.
That is correct. So when you did start out with the twins, I could tell 100% you knew, but when it came to articulating what you wanted to tell me, it didn't come out as the way that you wanted it, right?
Right.
So when would you deliver twins vaginally versus not? For me to contemplate a vaginal delivery, they have to be you can do that. They have to be not monoamniotic, monochorionic, and the first twin has to be cephalic. Boom.
Mm-hmm. Mm-hmm.
It, right? Doesn't that articulate everything that you were trying to say?
Basically, yes.
Right? In two very elegant words. I would consider a vaginal delivery in twins if the first one is cephalic, right? And it's non-mono twins, which means,
Right.
what implies that mono twins, and if the first one is not cephalic, right? And if you want to
Right.
add and be elegant and you say, plus all the other contraindications to a vaginal delivery that would apply to a singleton pregnancy.
Right. Yes.
Okay. Now, there's no right or wrong answer of what you do when the head gets stuck, right? Because if
Mhm.
you're not comfortable with putting a forceps on, you're not. But
Mhm.
in the real world, what would you do? If this happens and things get stuck, are you alone in a hospital?
No, call for help.
Exactly. Exactly. Right. And that's key here. And that's what I was waiting to hear.
Mhm.
You're put in a position that you're uncomfortable with what is going on. There may be Dr. X that is standing next to the door that has done all of that.
Right.
So you can say, in this situation, when I'm faced with this, even though I will try and look for a colleague that is more senior to me or has experience in applying these
Okay.
courses, right? That would be something that you would get back. Now, if you had told me, yes, I'm familiar with applying forceps, then I could have said, well, it's the same, but it's just the reverse of applying. But you said you've never applied forceps, so I really can't expect you to. But I've also heard in the exam where they have actually wanted you to go through the steps. So I think if you are going to say that I do end up delivering breeches vaginally, you can say, even though I have never applied the Piper's forceps, and I would not feel comfortable applying it. However, I can go over the theoretical steps of how it is applied.
Okay.
Right, so that would be something, because the last thing you want is for that to be the question, and you end up not getting the points. Well, all you had to do is just tell them the theoretical steps. The same applies to repairing the ureter, right? You never
Right.
should say, I'm going to repair the ureter, but at some point, that's what they want you to give them. So even though you're not going to repair the ureter, you can say, I would personally never repair a ureter. However, I can go with you over the theoretical steps of how to apply your ureter. Because if that was the point, if they say, yes, please go, that means the question was wanting you to answer this, but not in an unsafe fashion, but they want you to know how to repair a ureter, right?
Right.
Perfect. Sounds good. All
Good.
right.
Thank you so
very much. And you did well as well. Okay.
Thank you.
All right. Dr. Rivera, let's find you again now.
I'm here. Thank you.
I've learned you're up in my my place of. All right. So I saw your case list opening. So let me see now if I can get it. Is that it?
Yes.
All right. Technology, man, isn't that really good?
Thank you for your consideration.
Okay, sounds good. All right. Okay. Okay, let's go to case number 5. So tell me the circumstances that made you put a cerclage in this patient.
So this patient was 17 weeks and 6 days at the time of that visit. She had an ultrasound for her anatomy scan, her level 2. And upon examination, they noticed the cervix was slightly open on ultrasound. So I proceeded to do a physical exam. And on physical exam, she had 1 to 2 cervical dilation at that point. Membranes were not bulging. She had no bleeding or vaginal discharge and no pain at that time.
Okay, so how did you know that she was not infected?
On the ultrasound, there was no signs of amniotic fluid debris. And on physical exam, there was no vaginal discharge at all.
So would you have considered doing an amnio prior to putting in your cerclage?
It could be a consideration. At that time, the anatomy scan was negative, and she had a cell-free DNA that was negative as well.
No, what I meant is to exclude infection.
Oh, no.
I see. Okay, so do you think performing a cerclage on this patient carries more significant risk than performing a prophylactic cerclage at 12 weeks?
It does. It is
Okay, so
riskier.
how did you counsel this patient? What did you tell her were some of the risks that she may encounter?
Upon counseling for the procedure, we did talk about increased risk of membrane rupture at the time of placement, increased risk of prolonging this pregnancy for 4 to 6 weeks, which would place her at a severely premature delivery, risk of damage to nearby structures, bleeding, etc.
I see. Let's go to case number 13.
Okay.
Okay, so you have a patient with decreased fetal movement, correct?
Yes.
And it seems like that prompted you to do an ultrasound. Am I correct in my assumption?
Yes.
And the oligohydramnios was present, which made you do a contraction stress test?
Yes.
So why did you do a contraction stress test?
So at that time, her diagnosis was oligohydramnios. She had a single deepest pocket of less than 2. And we did talk about induction of labor indicated due to her oligohydramnios. And given the fact that she had small amount of fluid, I did wanted to see if she could tolerate a cervical maturation with misoprostol, given the fact that she had an unfavorable cervix at that time.
So you did a contraction stress test?
Yes, with oxytocin to see if she would tolerate or baby would tolerate labor.
But wouldn't labor tell you that anyhow?
Yes,
If you
but
put misoprostol, you would have achieved the same thing.
correct. But at that time, it would
She would
be
either
with,
decel or not decel.
sorry?
She would either decel or not decel, correct?
Correct, but I did not want to place a cytotech at that time if the baby were not to tolerate, given that I can't stop it.
I see. Okay, so please talk to me about case number 18.
So this patient at 35 weeks and 1 day presented to labor and delivery room with an intense pelvic pain and a small amount of bleeding. Upon connecting her to the fetal tracing, she had minimal variability and recurrent late decelerations, for which she was consented for delivery at that point.
And it seems like your gases were not in the desirable range, is that correct?
Correct.
So do you think that there was a delay from the time that the patient came till you went to the OR?
The delay was not when the patient arrived to the OR. It was 35 minutes from arrival to surgery, but the patient had been 2 hours on her way to the hospital.
I see. And it seemed like this patient had DIC, correct?
Yes.
So tell me, how do you make the diagnosis of DIC?
So for her, on her laboratory workup, she had platelets of 56 and her fibrinogen was 43, in association with her postpartum hemorrhage. The diagnosis was made.
Okay, so your diagnosis was made based on your laboratory evidence, based on laboratory evidence of DIC, is that correct?
Yes.
So I see you attempted a B-Lynch suture.
Yes.
Okay, tell me how you do a B-Lynch.
So for her, after closing the hysterotomy, her uterus was completely without tone. And despite uterotonics, it didn't resolve. Therefore, a B-Lynch procedure was made, and it was starting below the hysterotomy, basically under the hysterotomy was the first suture made. Then it was carried through the back. At the posterior end of the uterus, I did a horizontal suture in and out. And
What
then
type of suture did you use? And what type of needle did you ask for?
I asked for a CTX chromic 20, which is a absorbable suture.
Okay, let's assume that your B-Lynch did not work. What other options would you have considered?
So at that time, I would have attempted a uterine artery ligation, an Ole restitch, and along with further uterotonics at that time.
Would you have considered doing, would you have considered utilization of your radiology?
No, not at that point.
Why not?
Given the DIC and the vital signs, I would consider the patient to be unstable to transfer out of the OR.
I see. And you don't think that you don't have the capability of doing this in your OR?
No, unfortunately, we don't.
Okay. Would you have considered a hysterectomy?
Yes, if the bleeding wouldn't have resolved, the hysterectomy would have been part of the plan.
I see. Okay. Let's go to case number 41.
Okay.
How do patients with intrahepatic cholestasis of pregnancy present?
With pruritus of the palms and soles is the typical presentation.
And how do you make the diagnosis?
So at first, I do order a CMP and bile acids. The bile acids usually take longer to be reported. Therefore, if there is elevated in transaminases, that would be part of the diagnosis. And if the symptoms improve with ursodiol, then I would also be further
But
confirming.
how is the diagnosis made?
For her,
No, how is the diagnosis made?
so bile acids more than 10.
Okay. So you chose to deliver this patient at 37 weeks. Is that correct?
Yes.
Would anything make you deliver this patient prior to 37 weeks?
If the bile acids were more than 100,
Anything else that would make you deliver her before 37 weeks?
any negative finding on the antenatal fetal surveillance.
Okay, what about if the bile acids were, if the liver function tests were continuing to rise and the patient's pruritus was getting much worse? Would you
Yeah.
consider delivering her prior to 37 weeks in that scenario?
Yes.
What is the earliest that you would offer this patient a delivery in an otherwise reassuring fetal testing?
35 weeks.
Not 36?
Given the worsening of the liver enzymes,
Yes.
no, 35. If the symptoms were worsening and the patient had other laboratory testings that were worsening as well, and there are no other.
Okay, let's go to case number 40.
Mhm.
So was there anything that was suspicious in this patient's history that could have potentially made you predict that she could have had a shoulder dystocia or that she was at an increased risk of shoulder dystocia?
No, not at all. This was a thin patient with a prior unremarkable delivery, no gestational diabetes, nothing.
Okay, so walk me through the maneuvers that you would actually, and I just want the maneuvers of how you would manage a shoulder dystocia.
So first, stop pushing, then call for help, Meg Roberts maneuver, along with suprapubic pressure. If
Tell me
that
how you would do suprapubic pressure.
how I would do suprapubic pressure?
Correct.
So depending on the position of the fetal head, I would attempt to push above. Okay, this is hard to explain.
Exactly, that's why I'm asking you.
Okay, so
It's
above
your time is up. So remember, you want to push on the pubic bone or to the side of the pubic bone.
yeah, that's why I wanted this side is what I wanted to get to.
Correct.
Okay.
And I think that's where you were going, but unfortunately your time was done. You want to push on the side, right? And you want to push on the side where the occiput is facing, not where the face, because that's how you dislodge the.
Exactly.
Now, the most common mistake is people push on the pubic bone because it's called suprapubic pressure. But pushing on a bone dislodges nothing. You want to go on the side because what's the whole purpose of the pubic pressure? It's to dislodge the bone, and in concurrence with your McRoberts maneuver, right? You can.
Yeah.
So intrahepatic cholestasis of pregnancy, when I asked you how is it diagnosed, it is diagnosed by bile acids that are above 10. Now, whether that diagnosis is delayed or the bile acids come late, the diagnosis is purely made with the bile acids of more than 10. Now, you can have a high suspicion when the LFTs are elevated and the patient has pruritus and stuff, but can you actually make the diagnosis?
No.
Mic on.
Can you start them on ursodiol and assume that that is the diagnosis and put them in antenatal testing? Absolutely,
Yes.
right? But the diagnosis is made purely on the presence of elevated bile acids. Now, this is a little bit tricky. What's the earliest you can deliver cholestasis of pregnancy? Why? Because ACOG doesn't give you leeway, right? ACOG says 36 weeks, but SMFM does. Right? And SMFM says that if you have pruritus that is worsening, LFTs that are worsening, rapidly rising bile acids because of the increase, then you can individualize and offer them delivery before 36 weeks. So I leave it up to you how you want to approach this, but it is not unreasonable to 34 weeks and beyond in patients that you feel are rapidly worsening cholestasis of pregnancy. And the rationale for that is, well, we can't predict an IUFD even with reassuring fetal testing, right?
Mhm.
So it does not, you could have gone either way. And I leave it up to you what you want to do with that, but what you said was not incorrect. But you can go as early as 34 weeks. I don't mind how you explain the contraction stress test. I think that was very reasonable. Does everybody do it that way? No, they say your best bet is to trial labor. I think it's smart because so this is a case of, I looked at it and I was like, why did she do a contraction stress test, right? That's how I looked at the question.
Mhm.
But then you justified it not the question, the case list, but then you justified it in a way where I'm like, okay, that's good enough for me. I'm not bothered by it. Do you see what I'm saying?
Yes.
So you did well. Whether I would have done that or not doesn't really matter. Did you justify it in a way where I'm like, yeah, it makes sense. You put in the medicine, you can't take it out, and you run under merged circumstances. You wanted to see how this baby did under contractions because she's got oligo and she made D cell. I'm okay with that. I don't have a problem with it.
Okay.
Okay. Do you have any specific questions about how you answered something?
Regarding the B Lynch procedure,
Mhm.
do you have better wording for?
So I'm going to tell you to do what I did when I was doing I actually ended up putting these words for words, right? I actually had a Word document that I just put these and I just regurgitated them because they're difficult to just come and explain. But if you actually take them and read them from somewhere and just say, but I did not. You actually started explaining it well, which is why I asked you what suture are you going to use and what needle you are, right? So you're going to start from the hysterotomy, go backwards and kind of suspend it around and then go back from the back and go up again, right? That's how you're going to do the procedure. So I didn't have a problem with it. And by the way, right? You guys are back in doubts, right? Guess what you can do? You can say, is it okay if I pull out a piece of paper and draw for you how I'm going to do the procedure? That
Okay.
works. If you can't articulate, right? You can say, here's the incision. I put my first stitch here and then come back from here and then go to the other side and come back from here. That's okay. You can utilize, can I draw it for you? Can I show you how to do this on that? Because they know, all they want to know is, can you do it or not?
Okay.
All right. So, but I would just brush up on it. I don't think you did badly, but just do what I did for my exam is I printed out all of these lists, even the shoulder dystocias, right? The delivery of a breech. I just wrote them down and I just kept repeating them one after the other. So go through your case list and see any procedure you did, whether it's a 4th degree tear, 3rd degree tear, take it from a source, summarize it, and just kind of repeat it. Would be my recommendation for anything that is on your case list.
Okay. Thank you.
Okay, I apologize. We did go 6 minutes over, but I think you guys wouldn't mind too much, right? Probably not. All right, sounds good. Any last minute questions? Did you find this helpful?
Yes, definitely.
Okay, perfect. I will see you guys soon. I think I've got a good number of sessions with you guys coming up either in September or October, or anything like that. And I also may be meeting some of you on some of the mock orals, so we'll get to know each other a little bit more well. All right, you guys take care, okay?